we were presenting cases, and we presented a case of a patient who took 4 weeks of treatment, then their prescription didn't get refilled and they were off treatment for 6 days, and then they got their next supply, and the question is, would you continue treatment or should you stop because they missed too many doses? So one of the reasons for treatment failure might be that someone is non-adherent. So we had a discussion around the concept of treatment failure as it relates to non-adherence, and how many doses can a patient miss before you'd say, oh, my chance of getting SVR now is so low that I should stop, versus just continuing on. And I think there's actually our data to inform this, that there are studies that have shown that patients missing even 1 to 2 doses per week still have SVR rates that are equivalent to people who take every dose. And there's data being presented at this meeting in the population of persons who use drugs, where they've actually documented how many days they may have missed. So showing that even several days in a row, still these individuals result in getting very high rates of SVR. So that's reassuring to us that we should, of course, advocate for high adherence and reinforce the importance of that to patients. But if patients are missing doses, that we're still seeing very high rates of adherence. And so as clinicians, we shouldn't stop treatment in that setting, that we should continue on, complete the treatment course as was planned. They may have a few pills at the end that you should just, complete, but that we would anticipate that the SVR rates would be high. Now, as we move to shorter duration treatment, an 8-week course versus a 12 or a 24-week course, perhaps, missing a whole week of treatment may have more impact. So again, reinforcing adherence, and we talked a lot in the session about how do clinicians ensure adherence. We talked about the importance of phone follow-up as a way to sort of connect with patients to make sure that they're taking their medications, that they're getting their refills appropriately, confirming with them if they've missed doses, and again, reinforcing to them that it's important to do so. But that overall we have very effective drugs, so that a few missed doses don't seem to have any impact on our SVR rates. And that's, I think, reassuring information, because it comes up pretty often about, like, my patient has missed a few doses this month or has missed a few doses this week, what should I do? And the answer is keep going. Reinforce the importance to that patient of not missing doses, but keep going, complete the treatment course. Well, we are moving into treating patients that are less engaged with healthcare. So, as we move into treating individuals who are newly identified and may not be as linked with healthcare, we are certainly finding ourselves challenged by individuals that where adherence is more difficult for the patient and for us to do. They're not coming to the clinic regularly. They don't show up to do their lab tests. And I think the consensus among the experts, it's also within the group that we were speaking with in terms of clinicians, is that when they have a newly diagnosed patient with hepatitis C, or they have somebody that's been referred to them who failed a prior treatment course, is to have a good understanding of what happened the last time and what are the things that they could do differently to ensure that the second course is successful. And that means not only looking at were they adherent, but also looking at were there any medications that they were on that might have interfered or reduced their likelihood of getting an SVR. Kind of a key area might be, were they on antacids, PPIs, because we know that high dose PPIs can interfere with some of the drugs in terms of their efficacy. So reviewing what medications they were on, we would look at to ensure that the patient, again, had a regimen that was appropriate, that they had the appropriate dose, sort of thinking through why were the reasons that the patient failed, and trying to see if there's anything we would do differently the second time around. So those are the practical things. And then, of course, choosing a regimen that has a high chance of success based on data about DAA failures. So the good news is we actually do have very good options now for people who've failed a prior DAA therapy. We don't have 6 different options, but we've got 2 or 3 that are very good. And so we do have something to go on and retreat. Every DAA failure has an option in terms of retreatment. I'd say the ones that are more challenging are patients who have more advanced liver disease. So where we run out of where we have less options are patients who are decompensated, actually. So in general, if we have a compensated patients, there's very good options to retreat. The treatment options include sovosvir valpatisvir and voxilavir, so that triplet is a very frequently recommended. It differs by genotype, it differs by prior DAAs, but that's emerged as being one of the more frequently prescribed retreatment options. Gliclapivir, preventosvir can be a very good option for specific groups of previously treated patients, as can sofosbuvir, valpatisvir. So we have good options. Sometimes we still have to consider adding ribavirin. That's an old drug, but we still use it occasionally in that more difficult to treat patient population. And sometimes we look at extending duration. So, for the retreatment of a DAA experienced patient, we have new treatment options. Sometimes we have to consider adding ribavirin, extending treatment if we think they're a particularly difficult group to treat. And, that's where you have to look at the patient pretty carefully. It's not just what was their prior DAA treatment regimen, but am I dealing with a patient with cirrhosis? Because we know that cirrhosis is a little bit more challenging than non-cirrhotics. Do they have other conditions? We know that patients who have hepatocellular carcinoma, again, which we sometimes see lower rates of SVR, thinking carefully about how we're going to retreat that patient. And then the particularly challenging group is the decompensated patient, because that group we can't use protease inhibitors in. So that really narrows your treatment options. And so in that group, ribavirin becomes much more important to include, and where we have to think about extended duration more frequently. Well, I think I would say when, first of all, you have a patient who appears to have relapsed after treatment, is to always remember that they may have become reinfected. Right? And that's because we are increasingly treating patients that are potentially at risk for reinfection. So when somebody comes back with virus at week 12 after their treatment, you should repeat the genotype and the viral load, and of course get resistance testing, but to also query the patient about were they engaged in any behaviors that might have put them at risk for getting reinfected, only because we want to protect against another reinfection. So, reinforcing the issue of how do getting SVR doesn't protect you against getting your next HCV infection, and ensure that we're giving good counseling messages around reinfection. So we did talk about that too, because sometimes you'll see patients and you're not sure, could they have been reinfected versus a new infection. Obviously, if the genotype is different, it's a reinfection, but sometimes the genotype is the same, that could still be a reinfection. So asking patients about that, making sure that we're getting our counseling messages on board to protect against reinfection was also emphasized.